We're going to go ahead and get started this morning. Welcome. You're at Grand Rounds, Surgical Grand Rounds, and we have a very distinguished visitor with us this morning, Dr. Syed Nabeel Zafar, who's visiting us from the University of Wisconsin. He's part of a program sponsored by the Society of Asian Academic Surgeons. And what they do is they give scholarships and sponsor travel of up and coming leaders in their society to visit the top academic campuses in the United States. And we're very fortunate that he has selected to spend time with us today and tomorrow. He's an assistant professor of surgery in the surgical oncology division at the University of Wisconsin. He's also faculty at the School of Public Health. He directs their global oncology program on campus, and he's also director of the University of Wisconsin Robotic Surgical Oncology Program. He's a native of Pakistan and grew up in Karachi. And I just asked him, well, how can you live in Wisconsin if you grew up in Karachi where it's warm and humid, and Wisconsin's very cold? But he assures me that the weather is good there most of the year. He received his MBBS at Aga Khan University in Karachi, Pakistan, and we've actually trained several general surgery residents who've also graduated from that same university. He came to the US to enter a program at Harvard to get a master's in public health, and he was a Fulbright scholar also during that period, which is a very hard to get scholarship and really is for exceptional international scholars. After finishing that, he went to general surgery training at Howard University and then completed two separate fellowships. The first was an MIS fellowship at University of Maryland, and the second one was a surgical oncology fellowship at MD Anderson Cancer Center. If I were to list all the awards he's received, I would take up the whole hour. And he's just received many, many awards and has been really recognized for his efforts in surgical education, robotics, and HPB surgery. He's young in his career, but he has 124 peer-reviewed publications. His impact factor is 45. His H index is 45, which typically is at the level of very, very senior professors in most departments. He's a PI of an NIH grant, a DoD grant, and an American Cancer Society grant, all three of them, and is extremely productive academically. So again, it's really fortunate, Syed, that you're visiting us today, and we look forward to your talk from data to decisions, and you'll fill us in with the rest of that. We're looking forward to it. Thank you. And this time isn't right. Okay.
Let's take my phone out. Thank you so much, Dr. Philip. That was a very humbling and generous introduction. I don't think I deserve all of that. But it is a great pleasure and honor to be here presenting some things that I'm passionate about. I'm just gonna move myself a little bit closer to this mic. Hopefully it'll be entertaining. It'll be a little bit of a whirlwind. I often have too many slides when the time allows, but we get done on time. Some disclosures to start with. I don't have financial disclosures, but if anyone wants to hook me up, I'm ready. Some pictures are borrowed from the internet and colleagues. I tried to experiment with ChatGPT, didn't work well. It is a long talk, so please bear with me. I'll talk about who I am. Dr. Shulak did a very nice introduction, but where I come from, what drives me. We'll talk a little bit about the burden of cancer around the world, some of my work in pancreas cancer around the grants that were mentioned, and then how do we use data to improve cancer outcomes here in the US, but also internationally in low and middle income countries. We'll talk about my current work, ongoing work, and some future work as well. So the goal really is to understand how we can use data to make decisions and optimize outcomes, particularly for cancer surgery patients. Start with some quick definitions. When I say LMICs, I'm going to say LMICs a lot. It's low middle income countries. Basically, everything that is not blue on this chart is considered low middle income country based on the country's income or GDP by World Bank. I'm going to say PDAC a lot. PDAC, pancreatic ductal adenocarcinoma. We all know this, 90% of cancer. Data science, study of data to extract meaningful insights and optimize outcome. It's really just a new name, a buzzword for something we all do and have been doing for centuries and generations. So quickly about me, I grew up in Karachi, Pakistan, right there in the south, tropical, hot, humid, like Dr. Shulak mentioned. It's a population of 23 million. So that's the other thing. How do you live in a big city and come to live in a small city like Madison? I grew up in a family of doctors. It might be relevant to what I might talk about, but this is me back here when I was 7. So everyone in my family is a doctor. When I graduated med school, I'm like the doctor number 31, sometimes called the Baskin-Robbins doctor, but now there's over 40 doctors in my family. I didn't have too much of a choice. They pretended I had a choice, but that's all we knew. But related to that, we did have our own hospital. That's where I grew up. Just all my summers were spent in the pharmacy or the reception or the clinics or some part of volunteering in the hospital. My mom was always like, you can't just do nothing in your summer holidays, you just do something. But we went to a lot of rural areas in Pakistan to provide healthcare. My family had a big drive for giving back to poor people of Pakistan. So we would get on the train, go to rural areas in Sindh, the southern part, or the very north of Pakistan by the mountains, or in the desert areas. We would find like hospitals to partner with, which would be in pretty poor conditions with the ORs. We kind of fix up their lights and make it a little bit better. And then we'd operate, and I don't know if you recognize this, there's 2 surgeries going on at the same time in the same OR, one here, one light turned there, one light turned there, kind of a situation. But that's what my childhood was when earthquakes happen or floods happen. And then me and my family really did a lot of volunteerism there. And that's how I grew up. We also built a charity free of cost hospital. So everything in Pakistan is out of pocket, no health insurance, really hard to get good health care for if you don't have money. So we built a free hospital, which does a lot of OB-GYN stuff, but also a lot of teaching of community nurses and midwives. So that's really where my passion of health disparities and giving back and global health kind of came from. The other thing that was consistent when I was growing up, I love data. We used to play cricket a lot. I used to watch cricket a lot. But what I used to do, I don't know why I did this, but I had a notebook and I would record every single ball pitched, every run made by who and what the run rate was and all of that for every single game I could. And then I would try to predict who's going to win and next outcome, who's going to do what. And I don't know why I did this, but I had a notebook and I was just loved to do that. All the books I read were based on prophecies and prediction and fiction fantasy stuff. So very early on, I got really into using data and how to use the data to look at the future. When I went to medical school at Aga Khan University, as mentioned in Karachi, a lot of these questions have, naturally occur to all medical students, like how many patients have these problems? What happens to them? What do we do with this? And what if something happens different? And very soon I realized that medicine is basically a data problem and a prediction problem. So we collect the data, you do history and physicals, labs, tests, the data is being collected, then we process the data using some prior model, prior knowledge that we have in our brain and our textbooks. And then we categorize these patients into likelihoods, best guesses of what is wrong with this patient, the diagnosis, and then prediction, okay, if we give this patient this treatment, this is what's gonna happen. And then we do that, and then we collect the data again and see, okay, what happened to this patient, and we measure that, and then we do that over and over and over again over the centuries, and that is what the practice of medicine is, and it's essentially we end up with the right treatment to the right patient, what we call these days as data-driven decision making or data sciences, but it's been going on since medicine exists. But life is a data science issue. For every decision we do, or everything we do, where do you want to go to med school, how do you want to match, what do you want to have for breakfast, we get data, use data, classify, predict, we kind of measure or predict the outcomes. Are we going to be happy with our bagel this morning? And then use that again to get optimize the model again and again, and that's what intelligence is. And if you're biased like me, that's the meaning of life, and that's what separates us from humans and animals. how well we can use data. I was just mentioned after my med school, I went to do an MPH mainly because I was really interested in public health aspects. I just have this slide mainly essentially because at this time, all my mentors, everyone said, you want to do surgery? That's great. I mean, you want to do public health? Are you schizophrenic? Those two are completely separate things. And this was back in like 2008, 2007, when this field of surgery and public health really didn't exist or was in infancy. And so I get a lot of pushback and a lot of stress related to that. I just want to say that out for the med students and residents in the room. When you're making decisions, you're making your own path, you might get a lot of pushback from people you respect and mentors you do. But during my MPH, I kind of learned how to use data sets and large data. I worked with a bunch of mentors there. Some of them you might recognize, some people in the audience might recognize. Read a lot of books. Then I went back to Pakistan. I was part of the Fulbright program. You had to go back for 2 years. But I built a lot of collaborations between the US and Pakistan trauma registries. I taught a lot of surgical research methods. I built a trauma registry. So I was creating data sets, I was analyzing large data sets, and I was doing a lot of research capacity building. Kind of 3 themes that still go on in my life. We've already talked about this and Howard and 2 fellowships, and right now I'm in Wisconsin for the past 5 years. Other thing to mention, when I said I'm going to do MIS first and then surgical oncology, again, so many of my well-respected mentors said, what are you talking about? Surg-onc is maximally invasive, big cuts, big surgeries. You can't do that with laparoscopy and blah, blah, blah. But you look at the field now, it's totally very heavily MIS focused. But during my training, because I had the MPH previously and I had skills in data sets and data analysis, I didn't take time off again during residency, but I could analyze my own data. I knew what data existed where in M&Ms, in complications, in reading. If something happened, I was curious, okay, how much does this happen? Why does it happen? How can we change it? And I knew what data was in what data sets, and I could very easily analyze my own data and do the research. So it's pretty productive during my residency years. My practice at University of Wisconsin-Madison, I do GI, HPB, surgical oncology. Mostly half my cases are MIS, half are open. Half of my time is dedicated to research and academics, and that's health services outcomes research, which we'll talk about now. I run a data science lab, and also global oncology and global surgery, which I'm passionate about, how to improve cancer or surgical care around the world. So why cancer? Why am I passionate about cancer? As I said, when I came here to do my MPH, all my mentors were trauma. I went back to Pakistan, trauma research. When I was in residency, Eddie Cornwell, chief of the division, was also a big trauma surgeon. My family was in trauma. I thought I was going to be a trauma surgeon all the way up to PGY 4 or 5. Like 6 months before the application is when I decided, okay, maybe everyone told me don't do trauma. I thought maybe I'll come to Colorado for a fellowship. It's kind of an exciting program. But over time, I decided that that's not really what I wanted to do. And the reason is, this is what cancer looks like in Pakistan. As a medical student, I didn't want to be nowhere near surgical oncology. Everyone presents late. Everything we do is palliative. Patients are starving or poor. They just die in a few months, no matter what you do. It was really depressing. And why would anyone want to go in a depressing field like that? And if you see that in low middle income countries all over the world, almost 80% of surgeries we do for cancer are palliative, as very different to what we do in America. If you look at the spectrum of cancer care, from prevention, early diagnosis to treatment, end of life, in places like Pakistan, really we're just palliative, end of life kind of care. While here we really focus a lot on early detection, treatments for cancers. But this is a huge issue. But as I grew in my residency years, I saw how much we treat cancer patients, how much we cure. And that really bothered me a lot. Like there's a huge disparity around the world in how cancer is approached and what we can do for these patients. And I really got passionate about doing something about that. Also, it fit well with what I did want to do. I wanted to be broad. I wanted something that ties well with public health interest, and I wanted to do something life-saving. Those are the 3 things that was between trauma and surg-onc. So tough decision making, but I love. Ever since I decided to do cancer surgery, never thought back. But around the world, 1 in 6 people die due to cancer. I hate to do this, but everybody knows more than 6 people in this room. The Lancet published an article just not too long ago, a few years ago. For the first time ever, we show that cancer has really taken over cardiovascular diseases in high-income countries as the #1 cause of death in adults. In low-middle countries, it's still the #2, but it's rising fast. This is a graph that shows basically if is cancer the #1 leading cause of death or the #2 leading cause of death, or 3 or 4. But if you look at the dark figures, you can see that cancer is either #1 or #2 in most countries of the world. Where cancer happens is still in rich countries. So this is income level and cancer incidence. So the very high or high countries have more cancer incidence. That's true for now. But what we're seeing now is cancer incidence is increasing, and it's rapidly rising. And this graph shows where it's rising. Latin America, about 140%, Africa, 147%, just for example. And this is another graph essentially showing the same. It's what percentage cancer is rising in which parts of the world. By estimates, in about 10 years or so, 15 years, 70% of all new cancer cases will be in low-middle income countries. Low-middle countries do not have the infrastructure to support that volume at all. 18 million had cancer in 2018, 10 million died. Every country is seeing a rise in cancer. It's the #1 or #2 leading cause of death right now in 134 out of 183 countries. And in a couple of years, it will be the #1 cause of death in all countries in adults. Right? In countries like America or high-income countries, we've seen a decrease in cancer mortality rates. This is for breast cancer, a little bit older data, but you can see how fatality in both men and women are decreasing in cancers. But if you look at cancer data, which we don't have a lot of in low-middle countries, but let's look at just survival for different cancers in the US versus India. Look, there's huge differences you see in low-middle countries. They just don't have the infrastructure to support this. And this is the graph that I just want to imprint onto everyone's brains here. So cancer incidence going up, cancer deaths going up, cancer deaths in low-middle countries really going up. High-income countries, we're doing great. We're staying stable, probably coming down mostly, other than the incidence. But this is where the problem lies from a public health or global health perspective. When the volume or incidence is going to be so high and we don't have the infrastructure to support it, this is what happens. 70% of all cancer deaths will happen in low-middle income countries. So clearly there's a disparity in outcomes. One of the projects I did a few years ago is kind of look at, can we benchmark this? Where should we put our resources? How do we know which cancer we should tackle in which country? I do travel to different countries, and every country has its unique challenges. But we realize that there's no real way to understand which countries are doing better than others to control cancer. There's this incidence ratio called the mortality to incidence ratio. This number of deaths from cancer over number of new cancer cases per year. Instead of just looking at incidence, you're also looking at outcomes, so deaths as well. I want to take this a little bit further and look at benchmarking and see if we can look at the difference in mortality to incidence ratio, or what we call the delta MIR. And this is a resident who worked in my lab, Tom Deal, and Kaleem these are all med students at that time, superior students, and we published this in Global Oncology. Basically, we calculated the MIRs for 35 cancers in 183 countries, and we came up with a novel metric to look at variation. So if there's more colors, there's more variation, or more disparities or inequities, or however you want to call it. The red is what we found out who was the highest performer for each cancer around the world, and we compared everyone else to that. If you look at breast cancer, there's a lot of variation. Pancreas cancer, not much variation. Everything's almost the same color, 0 to 0.2. And it correlates with country metadata or country infrastructure. We did a bunch of validation tests, but this is Human Development Index. And you can see as Human Development Index increases, the disparity in outcome for cancer decreases. For colorectal and breast, which are screenable cancers, we can find them early, we can do something. But what about cancers of the GI tract or pancreas cancer, esophagus cancer? Not a lot of variation globally in outcome. Basically, this means we don't have good ways to deal with pancreas cancer, even in high-income countries. So I can't expect countries like Pakistan and stuff to invest a lot of resources in something that even high-income countries struggle with handling. But let's talk. Dr. Schulich did say, don't talk about pancreas cancer. He said that's the Bruno. But we have a lot of pancreas cancer talks, but it's what I'm passionate about. So I'm going to do a little bit of what I do in pancreas cancer. just to set the stage and just as an example of how I'm using data and data sciences, and this is applicable to any field in trauma or something. But I'll skip this, but soon to be number 2 leading cause of cancer deaths in the United States. Its death rate's been pretty stable. We haven't done well with pancreas cancer over time. 5-year survival has gone up a little bit, but if you notice, the axis is very small. I mean, it's a little bit ridiculous. We celebrate things like this. Breaking news, cancer survival is now 7%, 5-year survival of pancreas cancer. Oh, wow, we're in double digits now, yay. And then, you know, 5-year survival of all 13%. You compare that to other cancers, I mean, this is crazy. It's just, that's what frustrates me, and that's why I'm passionate about. But if you look at this graph, it's a little bit older data, but the red are people who get surgically resected versus not. And you can see the survival is much better for people who do get surgery for cancer, even over 20% 5-year survival rate as well. The challenge I have in the clinic every day when I'm talking to patients, this is me here when I used to have hair. Tough crowd today, yeah. No one laughs at my jokes. So I tell my patients, this is the Whipple operation, this is what we're gonna do, it's very complicated, blah, 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 blah. And 100% of them ask me, what then? What's the prognosis? Am I gonna live? How long am I gonna live? Every single patient asks me this. And I really don't have the answer to these questions. It's vague. I mean, that's the number one thing patients want to know. 100% want to know them. And I don't know. I tell them different kind of stats. It reoccurs in 50% in the first year or two. This is what it's going to be. I show them real world data. I show them clinical trial data, and if it's early stage and this and that. But they're really averages. But what does that mean to the individual patient? I really don't know. Median survival in real world data is, you know, somewhere about 2 years. But if you look at trial data, and this was a trial that came out not too long ago, but everyone was like, wow, 54 months median survival. That was crazy. Not even heard of. And we don't believe it. But clearly there are patients, if you select them well and you treat them well, they can achieve long-term survival. Just like this graph here, we know up to, you know, 20% survive beyond 5 years, while 50% will die. But for the patient, which category are they in? Are they in the better prognosis category or the worst prognosis category? We don't have a way of knowing, and that's the problem that bothers me a lot. So we have a limited understanding of factors associated with survival, and with limited ability to identify patients that are following different disease trajectories. The issue with this is when we don't know this, then we do a one-size-fits-all approach to treatment. And this is why I went into HPV in the first place, because I just cannot deal with breast cancer. In breast cancer, colon cancer, the treatment is so nuanced. Like if you have this and that receptor and this age, and if you live 10 degrees from the equator, this is how we're going to treat you if you're in this geographical area. And it's early stage, late stage, and it goes on. And this just hate breast cancer in the oral boards and surgery boards and every kind of board. It just goes on and on and on and on and on and on. And we just don't know. I mean, this is precision medicine. That's how you should treat patients with cancer. As opposed to that, pancreas cancer is easy. It's easy. You don't have to use a lot of brain work. Stage 1, chemotherapy and surgery, whatever sequence you may decide. Stage 2, chemotherapy and surgery. And guess what? Stage 3, pancreas cancer patients, chemotherapy and surgery. Sometimes you mix in a little bit of radiation. Stage 4 patients, okay. But this is really not precision medicine. And this is, I think, why we're so lagging behind in death rates for cancer. We just don't have a way to discriminate who to treat how. We don't have good agents. We have some non-specific things that are great, but not really there. And we treat everyone the same. So that was the theme of my career development award with the NIH, is how can we discriminate patients? Can we use data to risk stratify patients, and implications in personalized treatment, informed decision-making trials. It's kind of what I've been talking about. I started with saying our work, but it's an ongoing journey. It's been 5 years. We're still kind of struggling with it. But we did want to have a bunch of questions. What are the accuracy of prognostic models right now? What are the implications? And why can't we build better models? It is an important topic in pancreas cancer. There was a systematic review not too long ago. Over 3,000 studies just about this topic, like how can we better prognosticate outcomes in pancreas cancer. Most models were not well developed, retrospective data. But this is Clayton Marcinek, another surgery resident who worked with me in the lab a little bit. So we worked on we wanted to see what are the best models out there, what is their predictive accuracy in real world data. So we took data from 7 academic centers who had neoadjuvant therapy. The UNOC statistic is important. I might mention it a few times, so I'll spend a couple of minutes explaining this. So 50% or 0.5 is a coin toss. 100% is or statistical 1 is 100% accurate prediction. That never happens. But anything above 0.9 is excellent, above 8.8 is good, and above 0.7 is okay-ish. So we wanted to test how these best models that exist in the literature perform in real world data. And we saw that for 12 months, 24 months, 36 months survival, we did the AGCC's staging system or the MSK one, which were the most validated, well-used systems, really just had AUCs of 0.6. So not good, not good discrimination at all. So what happens if we do treat everyone the same? Another study that Clayton did was looking at what happens to these patients. We do these big operations. So we looked at the NCDB, everyone's pretty familiar with that, 66,000 patients here. We looked at patients who are getting Whipple operations, how long do they live? Knowing that if they're metastatic patients, they get chemotherapy, they get up to a median 11-month or 1-year survival anyway. So if we just treat them with the chemo, they're going to live for a year. So surgery should beat a year at least. That's kind of how we defined our futile Whipple. If you die within a year of diagnosis, that surgery did not really extend your life. That was the purpose. And we see in national data, 25%, a quarter of patients are dying despite getting operations. And this is NCDB data. So this is the best center or COC accredited centers, and a quarter don't have any benefits. We clearly need to do better there. 2 reasons: we don't have good data sets. We don't have good data. And that'll be a theme as I talk more about LMICs and global surgery as well. The other thing was previously some analytic limitations. We now have a lot of AI and machine learning, and I wanted to see if we could address both of these. We have a lot of big data, electronic health records and genomics and stuff, and can we combine all of that and then use some machine learning methods to get better outcomes? So that was the K word, and they were supporting literature on this. My mentor is a critical care scientist. He had a lot of data on sepsis and cardiac arrest. There were some data on breast cancer and colorectal that this is a signal and this could potentially work, help stratify patients so we can come up with interventions specific to patients. I'm gonna, the challenges, and I'll skip through a little bit of this just to kind of highlight the pain we went through, but we need to get the data, you need to clean the data, you need to analyze the data. Sounds easy. We got this data from ASCO Cancer Link. They had data for lung cancer, breast cancer, and I kind of asked them, hey, you're collecting all this data anyway, can you give us a data set for pancreas cancer? They're like, sure, $25,000 in the first year, $9,000 the second year, so on. NIH paid for it, I didn't care. But it was, it was very exciting data, 65,000 patients with pancreas cancer from 82 institutions across America, rural, urban, academic, non-academic, EHR data. So we have raw data for all of these different factors, diagnostic codes, laboratory codes. So very, very exciting. So all we have to do is, select the patients, get the outcomes, wrangle the data. It took me 1.5 years just to get through the regulatory paperwork, to get the data, to clean the data, to get patient selections. It was messy. It was bad. It made me cry. I still cry, actually. But, very soon we went down from 61,000 down to 1,500 patients. We could actually analyze all of the variables we wanted to. But we still did have a lot of variables or features in the model. We ran our machine learning. We did this fancy, work with the data scientists and work with a lot of different types of machine learning models. And just to show you the results, and just as a reminder, the good thing is all we had to beat was 0.6. So we didn't have to do too much. But so our models ended up with AUCs near 0.8, which is great. It's not perfect. We kind of did some machine learning explanations about what are the things that go into prediction. I'll skip that. If you have questions, we can talk about that. But really the insights I got here was big data does not mean good data. Just because you have a lot of data does not mean you can use that data and do it. Real world EHR data is extremely messy. It had a huge promise early on, and a lot of the AI world has come to realize that really what we need is high quality data rather than big data. But we were still able to use it to build a model with higher accuracy, AUCs of 0.8 to predict 1-year survival. So then I can talk to patients more about, hey, your chance of survival is not that high. Do you really want to have this operation, or there's other alternatives, or can we do more chemotherapy or something? But really, can we achieve better? What kind of results would we have with better data and other data types? If we include genomics or biomarkers or DICOM images or other things. And so that's kind of the next steps of our lab here. The other thing is that existing data sets, we know they're not built, like ASCO was not built for PDAC. It was not built for cancer. It was just EHR data. So some variables that are very important, stage, prescription, they're just not in the EHR. And we as clinicians don't do a great job of capturing everything. And it's really difficult to translate into clinical practice without addressing these limitations. So the model is only as good as the data is there. That's called the GIGO effect, or garbage in, garbage out. We've all heard about many times. So simultaneously, while we're going through this, we were like, okay, why don't we just create our own data and just create a multi-center EHR-based digital registry specific for pancreas cancer? We'll just work with our different institutions. We'll get that data. And we'll make the perfect data set and have the variables we need. So we did a systematic review, identified all the factors that go into prognosis, and there's about 600 of them, categorized them. And just to set the stage here, EHR data is basically two types: structured, which is numerical, objective stuff like vitals, lab values, diagnosis codes. And then there's unstructured, which is text and notes, and which is the bulk of EHR data. EHR data, 80% is locked within notes. We are very good at getting structured data elements, and still very poor at getting unstructured data elements. That's where NLP, LLM, and different things are really trying to make progress there. But conceptually, this is what we wanted to create. Like at UW Health, we wanted to make a pancreas cancer data commons, which would include all these data elements, including inpatient encounters, labs, genomics, the treatments they receive, the notes, the images, the pathology, H&E stains, cancer outcomes, surgical outcomes, diagnosis. And so we work with our key leaders in informatics and a couple of grad students and medical students, and then hired some research assistants. But the value, we also were able to link this EHR data with things like NISQIP, to get surgical outcomes with high quality data, obituary.com, which is vital status across the country, whether these patients are alive or not, Wisconsin Health, claims data, and American Community Survey, which has had a lot of social determinants of health data. We link this data, we put it on a platform, a cloud platform, Azure cloud-based, which we call Platform X. The value of that is any researcher from the institution can log in. They don't have to have special permission to my lab and my server to access this data to use it. And the idea being, we're trying to use a common data model. So everyone's EHR is very different. And we want to try to transform that so that when we do expand to multi-center, heart rate is a heart rate, a blood pressure is a blood pressure, the units are the units, and everything looks the same. So currently we have about 4,000 patients. We're able to link all of that. This manuscript's coming out soon. It's in press and in ASCO Clinical Informatics. This is the science, the informatics type of diagram for anyone who's interested in how we did that. But we're currently enriching this data further with DICOM images, trying to make it multi-center, trying to experiment with some NLP vendors to see if we can get notes data. We're experimenting with some novel patient-specific social determinants of health data to try to get that, and working on visualizations to help researchers. But in short, what we're doing is we're using existing data sets from ASCO, Flatiron, NISQIP, but we're also simultaneously in parallel making our own really unique data set to study this problem. And once we have the data, we can make predictions and examine outcomes. I took out a few slides here, just not talk too much about pancreas cancer, but we're using this data. We built a VTE risk prediction model. Early on, I had a patient being discharged, went home, died all of a sudden. I give everyone prophylaxis, but practices vary. It's like a blanket statement. It's just a one size fits all. Everyone should get Lovenox after discharge, but really there are people at high risk and low risk for this. Can we predict that better? So we're building a model. We built a model. It's good. We try to validate it and implement it. Similar, number one cause of death after pancreatectomies is infections and sepsis or readmission. So we're working on how we can build, fine tune, validate, and then implement some of that in the clinical setting. But then what I'm really passionate about disparities and outcome variation. And so we're using this data to look at that. Here's Clayton again and another, at that time, intern Carly. We looked at ADI, Area Deprivation Index, which is a composite measure of socioeconomic status that was, we have at the county level across the country, but also in Wisconsin. And we looked at, as your air deprivation index high or neighborhood disadvantage is higher, you're 3 times higher to have major complications, unplanned readmissions. This was just playing around with the data. We find this, and then we want to know why this happens. And Clayton got a grant to do some qualitative work with these patients to better understand their experiences about the issues, about why this happened. And this was also led to another American Cancer Society grant on understanding the social determinants of patients. But what we were finding early on is from this qualitative work, patients are really having a hard time at the time of diagnosis. And comments like I felt like I was left hanging and I had to figure this out all by myself. And that made us look at the data again and looking at the literature timing for patients. And I just read a recent article from here, right, Dr. Schulich and Marco on how important it is to get patients to surgery. If you get to surgery, you have much higher cure rates or survival, or however you want to call it, like I showed in those graphs. But there are certain patients, extremes of ages, low health literacy, gender differences, rural, minority, low SES, that have delays in care for pancreas cancer, 3 times longer to receive biopsies, 22 days longer to receive treatment. So we came up with an intervention about how we can include our nurse navigators earlier on in the process, and they can help patients navigate the health system, not after biopsy when they're diagnosed with cancer, but really at the beginning when they're imaging suspects they have. And really the median time is 74 days from imaging saying you have a pancreas mass to starting treatment. And that's a lot. For some patients even longer. But yeah, if you're highly educated, high SES, you're calling the doctor next day, you're getting treated in a couple of weeks or sooner, roughly like that. So this was a grant we wrote for the DoD, and the title said AI to help pancreas disparities or something. And then the elections happened. I thought this would never get funded, but it got funded. So we're going to give you some results of that in a couple of years. It's a 2-year project. So that's how where we are with my pancreas cancer work here at University of Wisconsin, the domestic work. But what about what we started talking about, low and middle income countries, and how can we use the same approach to optimize care there? The first question is, what are the outcomes after pancreas or cancer operations in low and middle income countries? So we did some systematic reviews. Patrick Schwartz, the resident who's working with me, he kind of led doing 2 systematic, we did liver, we did pancreas, and we did colon with survival. And this probably can't read this, but basically to show we reviewed like 50,000 titles and abstracts for each. And this is the data from low middle income countries. As you can see, big swaths of Africa and Middle East and all are just no data zones and very few data. Similarly for pancreas, very few studies in some countries are dominating. We can see outcome variation is a lot, but there's always even up to like 30% mortality after these kind of operations. I also had the opportunity to participate in the Global Surge 3 study, which is out of the UK, which basically looked at thousands of patients in 82 countries of the world for gastric, breast, and colon cancers. And if these are the graphs by income level, you can see low-income countries, much higher rates of complications for gastric and colon for sure. Not very much different for breast cancer. Survival data similarly worse. Insights here, severe lack of data. We just don't have outcome data in low-income countries, like 0 in low-income countries. Low middle-income countries, still some data, it's sparse. Long-term data also not there. Most studies are retrospective, low quality, but there are centers in low and middle income countries who have similar outcomes to high income countries. So it can be done. We can provide high quality, complex cancer surgery in low middle income countries and achieving the similar outcomes as high income countries. And then because of our analysis, we have a kind of a baseline benchmark to do against. The importance of this is that over 4 million, this is a little bit older data as well, but there's not an update on this yet, but there's 4 million perioperative deaths and complications each year from the 300 million surgeries that are being done each year. The number of surgeries being done each year is much higher than the number of children born each year. When I talk in the public health setting, that's a big surprise to everyone, of course. This is a surgical crowd, so everyone expects to have a lot of surgeries here. But over 4 million perioperative deaths, that's much higher than HIV, TB, malaria combined. But all of our resources in the world of public health and global health are in these areas, which lead to 3 million deaths. And I would say, perioperative deaths and complications is much higher, much more important, but gets much less attention. Also, it's disproportionate. The surgeries that are being done in low-middle countries, less than 10% of the world's surgeries are being done there. But the perioperative deaths and complications severely dominate. 50 times higher death during childbirth, higher SSIs, higher mortality. And if you look at the volume of surgical research being done in these countries, that's also a big problem. This is the USA. Cancer research, cancer surgery research, and general surgery research. That's 30% of the global research in this area is from USA, and then obviously China dominates there. If you look at where I'm from, Pakistan, probably in the decimal fractions of where this research is coming from. So we need better data. We need better data systems. We need to build capacity for outcomes research, and we need to improve the quality of research here. And that's kind of what I do focus a lot on: creating data sets, analyzing large data sets, research capacity building. I'll give you an example of some of the work we've been doing. And this is just by my experiences here in America, using different data sets and the NSQIP data set, and how we use NSQIP to improve outcomes locally in our own departments. And NSQIP has been very popular and very successful. And there's similar things in Europe, in Japan, and in other fields of surgery as well. They all basically work similarly. There's a big backbone of good data, risk-adjusted or outcome data, and then there's all these patient factors and stuff, and then you analyze the data and you look at your outcome. But really building a system that can reliably collect data is an important first step. And just showing some NSQIP-related slides here. To get high quality surgical care, you collect the data, you analyze it, look at the outcomes, you give feedback, you start doing quality improvement projects, you see why you need to improve it, and then you do it, and then you just go round and round that circle. And then this could boast a lot of benefit to decreasing post-op complications and mortality around in America, and similar in other fields and around the world. But can we do this in a low middle income country setting where resources are poor? Can we collect high quality outcome data? Can we continuously collect this data? And why not? And what can we do to make this happen? Those are some questions that I started working on several years ago. The first thing we did is to get examples of studies that have collected surgical outcome data in low middle income country settings. And then there were clearly a lot, like 25 countries, 53 countries, 66 countries, 82 countries, high quality, 30-day outcomes. But these are all snapshots. This is Taylor's a resident from MCW, Tom and Dowdow from University of Wisconsin, who worked on these projects with me. But yeah, we can collect outcomes and we can collect them, but these are snapshots. Can we collect registry level data in low middle, meaning continuous data? Another couple of students from Pakistan and different places in America worked on this scoping review. Mostly it was trauma registries we found in the surgical world, and this is where it was. We used a framework called the PRISM framework that really divides issues or challenges into technical factors, organizational factors, behavioral factors. So really trying to understand what are the issues, why can we not collect outcomes data? And just telling this about an example of how I approached solving this problem. We kind of understand it better. Insights we gained is that data collection for risk-adjusted surgical outcome is very possible. There are examples of ongoing registries, but there's not enough on data on why there's not enough longitudinal, especially in the surgical perioperative space. There are some in trauma. So we did a survey using our survey center in Wisconsin that also costs a lot of money. But this survey was a social media survey, an internet survey, so very reliable. I mean, it is a actual research method. And we got 500 responses from 34 different countries of the world, analyzed that, looked at some of the key barriers clinical responsibility is high, research-related costs, funds, and everything you could expect, whoever works in the global health space there. But we also asked them, what are the solutions you propose? So they were like electronic collection platforms, dedicated personnel, some teaching sessions to teach us how we can do this. So those were the insights we got here, just similar to how we approach our disparities research here. We're using the data to inform our research and create interventions. So we partner with the university in Ethiopia called the Hawassa University Hospital. This is a picture. This is their medical record system there. And clearly it's really difficult to collect any kind of patient outcome data here. But we took on this challenge. We had a thought in mind, maybe we can use mobile health technology to do this. We use the RedCap app, which is mobile health based. It was an iterative, roughly 6-7 month process. This is during COVID, and I just virtual meetings with people in Ethiopia, made a list of variables. What is important? What can we do? For the first time ever, we're trying to do 30-day outcomes in a continuous manner. We developed the mobile app version of this, which was great because it doesn't rely on the internet, which is not there. People can use their own smartphones to collect data. It's a cloud-based storage system, so not a lot of infrastructure cost here. And this is what they asked for. My resident, Tom Deal, went there, had a good time there. He trained them for a couple of days on how to use RedCap to do this. Taylor then finished up the manuscript. We used some implementation science here, using the pre-seed, proceed model to get buy-in from the IT and the hospital leadership, and really went through a robust process of how to do this. Then we collaborated with Stony Brook to create some data visualization. So this is on the website. So any surgeon in Hawassa can look at their own data, toggle through what's the age of the patients coming in, was it urgent, was it emergent, what are their outcomes, and they're using this in their biweekly M&Ms to look at what's going on, and then developing steps. And our next steps here was, can we make it multi-center like NSQIP? Can we do risk adjustment like NSQIP? So we used that, and Taylor was successful getting the AAS Resident Global Surgery Award to do that, and he's doing semi-structured interviews. That's done, going to be published soon. And then can we develop risk-adjusted models for low middle-income country setting? So that's kind of ongoing work. Then piggybacking off of this is, what do you do? What do you use the data for? So we got a 3-year award from the Riley Baldwin on working with Zambia and Ethiopia, Department of Surgery and Anesthesia, to really see how we can use this data. So we're going to expand the registry in Ethiopia. Just give me a second, talking too much. Yeah, so we want to expand this in Lusaka, Zambia, which is another hub site for the American College of Surgeons. We want to build capacity in quality improvement using this data. So we built a bilateral exchange program where we go there and teach, but surgeons also come here and develop. We develop QI champions, some mentored projects, some online and local in-person workshops on quality improvement, which includes not just surgeons, but anesthesiologists, nurses. And after the first iteration, that we also now included ER providers and ER doctors, OR pharmacy, OR lab. So now the whole institution is really involved and invested in doing surgical QI. These are just some pictures of our workshops and trainings that we're doing in Zambia and Ethiopia. And it's really shown a difference about, do you understand the basic concepts of QI pre and post, the Likert scale, much higher. Are you going to do a QI project over the next 12 months? And we're seeing a big difference from pre and post surveys. But also what came out of this data is research. And I talk about research capacity building as well. For the first time ever at the regional conference, COSEXA, which is 24 countries in Africa, we had 7 residents from Hawassa, Ethiopia, present their abstracts there. That was 25% of the whole conference was residents from Hawassa presenting their work there based on this data. We're going to end soon, and I'm just going to end with a little bit of cancer registry work we do. A few years ago, working with another medical student, we looked at where are there cancer registries in the world. And as you can see, a lot of the low-income countries don't have population-level cancer registries, which is a big problem. If we don't have the data, we don't know what's going on. We don't know the incidence, we don't know the outcome. So we're working with Hawassa to build first we did a retrospective cancer registry, and we did a prospective one, and we're making phone calls to patients for the first time ever. We have survival data. It's the phone calls work in 50% of the time, but at least we have 50% of the data. And then we can now link this cancer registry data to our surgical outcomes registry, which is the first of its kind in an LMIC setting. And just on that note, in Pakistan, just to see how you can use data to drive policy, even in this just happened recently. I'm very excited about it. But we've been talking about cancer registries in Pakistan for a very long time. Even from a distance, we wrote this pretty robust article. One of our students, our grad students, did this on where the cancer registries are, what are the challenges, really a big call on why we can have cancer, and in contrast to that with India and on what's the cost of it. And it's got a lot of media attention. Dawn is the leading newspaper, and this paper was talked about there. What date? July. Paper was published just before that. And you know, one day I woke up to this news here that Pakistan is now in September has signed a bill that they're going to invest resources in the National Cancer Registry. So policy work is important with your data and your research. And this is the Lancet Commission in Global Cancer Surgery that I had the opportunity to participate in, and we were able to inculcate some of our principles of what I think are important. Patient safety and quality improvement in cancer surgery, and enhancing the role of research in cancer surgery, two key items in how we can tackle the burden of cancer surgery around the world. Key takeaways, so that's the end of my talk, and just kind of reiterate a few things. I think outside the box, a lot can be done remotely. When I'm doing global health work, a lot of people are very interested, but they don't have logistics or interest or ability to travel. A lot of my research is on publicly available data that can lead to policy. Don't fear the unbeaten path. A lot of people have said no, and this is not possible to me throughout my life. So don't say that. Team science is the best thing ever. And we are surgeons, we know that, we believe that, we work in the OR, especially those in cancer. Cancer is a major global challenge. Everyone here who is not differentiated should go into cancer surgery. Of course, there's immense value in using data to study and improve outcomes, but big data is not always equal to good data. Use data to make decisions. This is one of my mentors. I'm going to close with this. Had said this to me once as ABCD. Basically, it means always be collecting data. Big thank you to everyone. Thank you for the University of Colorado for inviting me, and the organization, and all my mentors and support teams throughout the way, and the funding agencies, without which we can't do the thing that I'm passionate about doing. Happy to take questions. And Madison is a beautiful city, and whoever is looking for a place to be, please come to Madison. We're happy to host you there as well. Thank you so much.
Dr. Zafar, let me be the first to congratulate you on this wonderful talk. It was a whirlwind of information, and I'm sure it's just a small piece of all the things that you do. So I have a couple of questions that kind of go in different routes, but you know, a Whipple operation may actually be more cost effective in a low to middle income country, if it's possible to do. You compare, you know, 5 hours in the operating room with scissors, cautery, and some suture, compared to chemotherapy, radiation therapy, all the other things we use to treat. And doing a Whipple operation is cheap. You know, these patients typically don't even have to go to the ICU. And, you know, those countries may actually derive more benefit by taking those patients to the operating room. What are your thoughts on that?
Yeah, I think excellent thought. And I think, you know, we, with our collaboration with Hawassa University in Ethiopia, through the American College of Surgeons, we were able to train a general surgeon who's been out in practice to get HPB fellowship. Now he's there for 2 years now. So I do 2 trips a year to support him in his cases. So we are now doing, he's the only HPB surgeon for a population of 20 million in southern Ethiopia. So he's doing now Whipple operations and liver resections and things. And you're right, it's just one light in the OR that goes off, one cautery, electrocautery that barely works. You know, one time it just, sometimes it's just on all the time, and I burnt the colon once, just putting it down. But it's possible. Just suture, cautery, scissors, light, and you're able to do, and patients do have good outcomes if you're studying the outcomes and really doing it safely. That's the key. I think that's the key. If they have good perioperative outcomes, that's when it helps. And true, there's no radiation center in that population for 20 million. They can't get radiation. Traveling back and forth to get chemo is really cumbersome and difficult. So yes, surgery is a very cost-effective solution to a lot of problems, contrary to what a lot of people believe, even complex surgical oncology. So I do highly believe that if we can get over the perioperative mortality part, that's probably has a big role in long-term cancer outcomes. Yes.
You know, and then you made a point about, you know, what do you say to the patient that asks, well, I get a Whipple, then what? And what I typically say, if we can't do the Whipple operation, you know, typically it's a year, right? If we can do the Whipple operation, typically on average, median, whatever you want to use, it's 2 to 3 years, right? But and so, you know, giving somebody 2 extra years of life is a big deal, I think. And you know, that's why we do what we do. Also, dying from unresected pancreatic cancer is not a lot of fun. You know, it causes a lot of local problems. It metastasizes. So, you know, and also most modern centers now have a 30 to 40% 5-year survival rate after a Whipple operation. So if anything, I think we should be more aggressive now. But you're right, selecting out the patients who quickly recur with metastatic disease would be doing a huge favor to a lot of patients and to a lot of surgeons. So I agree with that.
And I'll just comment, and absolutely, the reason for me to risk stratify patients and predict is not the choice between surgery versus not, although some patients may have better quality of life with radiation for surgery, but really that's not the question. It is about what else can we do? Better treatment monitoring, maybe changing how we do chemotherapy, different kinds of chemotherapy, opening up to interventional trials. And if you risk stratify, clearly I mean, the numbers, I mean, you know better than, but similar in high income, high academic settings. But still, you know, we do see those early recurrences. We do see patients with low-grade tumors, no lymph node involvement with Mets in 5 months. And in the national data, we see 25% dying within a year of operation. So what can we do more for those patients? What can we do different for those patients? So we need to know who's following what trajectory early on.
Yeah. And, you know, one strategy is give everyone neoadjuvant chemo to really understand it, but that's debatable. At last is kind of a comment. So coming from Wisconsin, I thought I would see Epic all over your, you know, slides. I don't think I saw Epic up there once.
So, yeah, so anyone who comes to visit me in Madison, I take them to Epic and encourage all of you guys. Epic is I mean, the buildings, they've got 5 or 6 buildings. They're all thematic. There's a Dungeons and Dragons one, there's a different one, and they're all decorated nicely. I take my kids there. It is huge. Epic has made our lives much easier, or any kind of integrated electronic healthcare system. But the challenges are there as well. And if you see Epic at UW, it's different from the Epic in Colorado. The challenge is, how do you harmonize that data? They've definitely, there's pros and cons. I think I'm a big supporter, but they're the custodians of data. So a lot of the AI integration and stuff. But a lot of what I can do now is because the EHR exists across the cities. But yeah, next time I should give more credit to Epic in my slides. Maybe they'll give me a financial disclosure as well.
Any other questions, comments? Yes, Paul.
Thank you.
I have a question for you. How did you get, excuse me, local engagement to get so much success, particularly in that registry in Pakistan? How do you get local engagement to really be the stewards and leaders in driving that forward?
By local, do you mean in America or in Pakistan or Ethiopia?
Within country?
Within country. Yeah, so it's a slow process. A lot of global health, what I tell people is, 50% of the work is relationship building. Just like if you have a translational science, half the work is feeding the mice, cleaning the poop of the mice, taking care of the mice. So relationship building that doesn't get accredited for. So a lot of meetings and talking, and people want to do the right thing. There's no question. Every surgeon I meet everywhere, they want their patients to do better. They want their patients to have better outcomes. Being in America, the advantage is everybody sees us already with the bias, or you guys have figured it out, now please help us do what you're doing kind of approach. So it's very easy to convince people, hey, this is what we do here, let's try it out and see how it works. The challenge is they have the passion and motivation to do it. The challenge is, do they have the resources to do it? Do they have the time to do it? That's where we can really pitch in, and if our students and our residents can go and show them something, because we can't go there all the time, every time. But collaborating with other centers, and if multiple faculty are going, saying the same thing, bringing them here, showing them how we're doing it, that's really what changed a lot, really working with the leadership. And the passion, the drive is there, and then we provide some of the resources. I will say the Ethiopia registry, a big goal of that was not to pay for data collectors. We want it self-sustainable. So we work with the hospital to figure out who is going to do it. And they have a GP system where after medical school, before residency, you have to work in the hospital, do something. So they're the ones who collect data. The hospital invests in it now.
It's either one quick question.
Excellent talk, thank you. My question is, you have done a lot of database research, obviously, and one of the elements that emerges from treating complex cancers is that volume matters, right? When you get people to tertiary institutions, outcomes get better. What do you think are the efforts that can be done to improve access of the population to tertiary care? Because there's a huge proportion of the US population that just never has access.
Yeah, I mean, different answer for different countries, and I don't know. There's a lot of telemedicine, AI kind of resources there. I know what centralization is a contentious and controversial topic, but I guess the quick answer is I don't have an answer for you on that, but I do think it's an important issue that is worth studying.
Congratulations. Thank you. Another round of applause, please. Here's a goodie bag
awesome.
with some University of Colorado stuff. And we look forward, he's going to be joining us in the operating room and then meeting with a whole bunch of folks and the residents. Thank you.
Thank you so much. And thank everyone for coming this morning. It was a great honor.
Let's get a picture.